In this presentation, we'll be covering the radiographic positioning criteria for the esophagus. With the advancements made in digital imaging and the ability to capture clear images during the radiologist's fluoroscopic routine, we're seeing less and less facilities which require these views. It should be noted that these views are performed after the radiologist's fluoroscopic evaluation and often require administration of additional oral contrast media. Views we'll be covering include the PA or the AP view, the obliques, which can be performed either RAO or LAO or both, as well as the right lateral. Before we begin the details for positioning, it's important to mention the evaluation criteria for each of these views. They need evidence of proper collimation. Esophagus should be visualized from the lower part of the neck to its entrance into the stomach. It should be filled with barium, and you should have radiographic penetration of the barium. For this exam, preliminary patient prep is not mandatory. Exams can be single or double contrast. For single exams, either barium or water-soluble iodinated contrast may be used. The first part of the exam performed with the radiologist is a functional study of the patient's swallowing. You typically utilize a 14x17 image receptor with some side-to-side collimation, at least 12x17 collimation, and more if you're able to, depending on the size of the patient, to include the lower neck to the gastroesophageal junction. Central ray should enter T5 to T6, and the esophagus should be filled with barium. It typically takes 2 to 3 large swallows to fill a patient's esophagus with contrast for the entire length of the esophagus for this view. We'll discuss specific instructions for drinking in lab. For the obliques, RAO and LAO are typically performed in the anterior oblique position. This way, the cup can rest on the table and the patient can comfortably hold the cup of contrast and minimize the risk of choking or aspiration compared to an attempt to perform this view in a supine position. Start the patient in a recumbent position in a 14x17 image receptor with at least a 12x17 collimated field or a smaller field if you're able to. Collimation should include the lower neck all the way to the GE junction with a central ray approximately 2 inches or 5 centimeters lateral to the MSP. In the image on the left, we see 3-view representation of the esophagus. Note the far left view, the AP. The esophagus superimposes the spine. However, when we rotate the patient for the oblique in the second view, it frees the esophagus from superimposition over the spine. We can also see 2 indentations here from the adjacent anatomy, including the aortic arch and left main bronchus that we mentioned in the previous slideshow. The image on the right is an RAO view with single contrast with no air. From left to right here, we see an oblique distal esophagus view with double contrast. Barium is used to coat the lining of the esophagus, while air is added and expands the esophagus. This creates a superior view of the esophageal structure. The middle view is a PA oblique in the RAO position, followed up by an AP view in the LPO position on the right. We're responsible for hanging these images just as we would any other radiograph in the anatomical position. For the lateral view of the esophagus, the patient should be placed in a recumbent position facing the radiographer with arms brought forward to avoid superimposition of the arms over the esophagus in this view. The central ray should be directed to the level of T5, T6 at the mid-coronal plane. A 14x17 cassette can be used with at least a 12x17 collimated field to include the lower neck and the GE junction.